Yeah. Thanks a lot. My membership number is K17849, and at the outset, none of the authors have any financial disclosures to make pertaining to this study. This was a LASIK patient who came for a refractive surgery in 2005, but we found that all the indices were normal, but we found the topography was not within normal limits. So we asked her to be on hold and come after 6 months or a year. But surprisingly, she came back to us after 5 years, and over the next few follow-ups, we saw that she was going into keratoconus and developing ectasia. So what if my LASIK patients show this change if I operate them and they don't do it before? There are various risk scoring systems available in the literature, and we do use them each day, and also the PTA and the residual stromal bed thickness. But are they sensitive enough, or how do we assess abnormal topographies beyond this ectasia risk scoring systems? These are the topography maps of the same patient. If you see from 3 different machines, Pentacam, Opscan and Galilei, they all look the same, but which is the best for detection? And they all have the keratoconus screening indices, but are they reliable, sensitive and specific enough? We need to know that. They are all Kleinfeld based devices, which gives the best of image quality and also the best of scans, and with minimal distortion. And also they have the multiple keratoconus screening indices, but the sensitivity and specificity of each of them for the Indian population is not known. So, is there a perfect topographer to screen these refractive patients, and which keratoconus index is most reliable and which one do you use? And also, can we differentiate the subclinical keratoconus? So, the purpose of our study was to determine and compare the predictive ability of 3 different Kleinfeld-based devices in differentiating keratoconus and subclinical keratoconus from normal cornea. It was a retrospective cross-sectional study with 70 normal eyes, 84 subclinical keratoconus eyes, and 92 keratoconus eyes. They all were subjected to all the 3 scans, Pentacam, Galilei, and Cirrus, 3 readings each, and a statistical analysis was done for sensitivity, specificity, area under curve, and positive and negative likelihood ratio and predictive value. What we found for the sensitivity between the keratoconus and the normal eyes was, for the Galilei, the surface asymmetric index showed the highest sensitivity. In Pentacam, the relation thickness, the Ambrosio relation thickness average and the average pachymetry progression index showed the best sensitivity. And in Cirrus, the 4.5 millimeter zone of root mean square values per unit area back showed the maximum sensitivity. There is enough literature on Pentacam and Galilei for the best sensitivity and specificity, but for Cirrus there is no literature present. Also, the specificity for Galilei was best for percentage probability of keratoconus and surface regularity index. On Pentacam, it was the index of height asymmetry, and on Cirrus, it was the symmetric index back, Beloshi-Kaloshi-Versace index, and the 8 millimeter zone of RMSB. How do we distinguish between, and which is the best parameter to distinguish the subclinical and the normal eyes? It was the standard deviation of corneal power in the Galilei, bad D of course in Pentacam, and the symmetric index front in Cirrus. And the best specificity was found in Galilei with surface regularity index of IHA and minimum height in Pentacam, and RMS SB of 8.5 millimeter zone in Cirrus. Comparing parameters for the best area under curve, bad D was statistically similar to that of SRI on Galilei and RMS-A of back on Cirrus. Comparing for normal and subclinical, the best parameters, bad D was similar to that of SDP on Galilei, but bad D was better than RMS-A back on Cirrus. So predictive ability in distinguishing subclinical keratoconus is not strong enough, and we need to have better tools. Bad D was of course the strongest indicator, as it's a multivariate analysis and the regression analysis has been taken care of, that's why. So that's why it was the best parameter. To conclude, keratoconus indices measured by all 3 machines can effectively differentiate keratoconus from normal. However, a combination of data is required to distinguish subclinical keratoconus from the normal eyes. And this is the first study to give the most sensitive and specific indices for each of the 3 devices for the same patient. Almost all the indices have sufficient strength when differentiating keratoconus from the normal cornea, but not while distinguishing subclinical keratoconus from normal. So we need to have a combination of indices. However, different grade of keratoconus are not compared among the 3 topographers, and only the screening indices are studied. Thank you.